Do any of these patients receive support or education from those that are caring for them at any point? So just a little discussion on the support and education that you feel are given to patients who are experiencing pressure ulcers.
Yes, absolutely. And I think that it's a good question, and it does really reflect on what information do we give the patients, and is there we do give information leaflets to patients and carers, and we record that that's what we've done, and the nurses will also record when they've had that discussion with the patient and family about the importance of preventing pressure ulcers. But I think the question is, how do we know how much the patient takes that on board and how much the family really understand? And when we listen to what David said at the end, he was told about pressure ulcers, he was given that information, but there was this element of, I didn't really take it on board, I didn't really think it would happen to me. So there is an element of how do we get patients to engage in that, and maybe there is more. We've got a video that we show patients, we've got a leaflet that we give them, we've got an information plan that we give to carers. So there are those resources that we put into place. But how successful it is, we maybe know less of.
It says, being a staff nurse working with the elderly in acute medicine, it's often the confused patients that suffer from pressure ulcers, as these patients can be difficult to position change. So I guess this is looking maybe at hypermobilization, active, somebody who's very active versus somebody who's not getting any positional change. And second part to that question is, do these pressure sores impact even further the adverse effects of COVID during the pandemic? So has that level of confusion further exacerbated? So just to both of you, really.
I remember a patient in a care home once that we were asked to go in to support, who had hypermobility and walked up and down all night, and this patient had dementia, and they developed pressure ulcers, to their feet, underside of the feet, heels, and we managed to get them like some certain support shoes where you can offload and things like that. But it can be difficult, and from in a sleep situation where it's hard to reposition people, speak to OTs, therapists, that collaborative working, because there are sleep systems designed to help to keep people in certain positions. So I don't know if Alison, if you've got anything.
Yeah, no, I was thinking of the dementia outreach team that we work closely with to look at those sleep systems, which are for patients with severe dementia. Another sort of thread is the risk of contractures with those patients with severe dementia. So they're for prolonged bed rest rather than hypermobility, where there are different risks of contracted hands, and different pressure points on the body, the heel pressing onto the buttock, for example, because of contractures that you might not see without that level of dementia. So it's a very complex group of patients that, and really what you're going to be doing and how you're going to be relieving that pressure or reducing friction from excess movement perhaps is very individual. But there are anti-friction booties, anti-friction sheets that can help. But knowing the resources out there is critical, I think, this is the problem, how can we start to resolve this?
Yeah, and the person who asked that question said there was a staff nurse on an acute ward, and to do utilise your specialist services that are there. If they don't know, then they don't know to come and advise you. Yes, certainly with COVID, if for patients who have COVID, you get reduced perfusion and etc. And so they definitely, people had an increased risk for sure.
I've got a question asking for patients who have category 3 or 4 pressure ulcers on their ischial tuberosities. What are your recommendations on seating out in the community setting, please?
We would, as a tissue viability service, recommend not sitting on category 3 or 4 pressure ulcers. If there is another reason, like the only time the patient can eat and drink when they're sitting out, is there any way that they can eat and drink sitting in bed? But if interventions have been tried and the patient has to sit out, then we would say, you know, well, we have to take that important aspect of prevention into account and management, but only for meals. So to maximize that time, you know, to an hour maximum, providing they've got a high level of pressure relief. And there are, of course, pressure relieving cushions available that are alternating. There are air flotation type cushions. So you would up the level of cushion to be able to enable that patient to sit out, because sitting out and everything we heard about this, you know, prolonged bed rest and the impact that has, sitting out of bed is really important. So I think it's a really good question. But if somebody's sitting for prolonged periods of time on a category 3 without that higher level of pressure relief, the pressure ulcer will get worse.
And
so it's a fine balance.
Yeah, and it's those, like, back to those conversations and informing the patients and their families and carers, because it is so hard, isn't it, to say to somebody right now, you know, you're going to go on to bed rest, because we don't want to be dictating to people, you know, what they're doing. And it's about developing that care plan with them. And there may be times when, you know, a seating plan is part of that. But I mean, you know, just listening to your videos, Alison, of your patient stories, and I know I did one 2 years ago, Diane's story, and I actually retweeted it yesterday, and Medstrom kindly sponsored us to create that video at the time. And, you know, it was the same situation, and this lady had to, you know, she was in bed for, I think it was about 2 years. I mean, thankfully her pressure ulcer was now healed, but it was a category 4, and that was the hardest thing for her, because she was very social and very active. So it's, you know, it's the approach and things, and making sure, you know, profiling beds can be turned into a chair.
Yes.
You know, yeah. So you have to look at, you know, all the different aspects of care.
Okay, thank you. So another question: when does a pressure area become unavoidable?
I'll start with that then, Alison. That it's a difficult question. Firstly, we don't use the NHS improvements recommended in 2018 that we don't use the word avoidable and unavoidable, because it suggests someone's being blamed, and that's not what the reporting of pressure ulcers was ever meant to be about. It felt that that's what it was when we started to use this is avoidable, this is unavoidable, and so it's about lessons being learned, and that's very much the approach now. What can we learn from this? We're not pointing the finger, making somebody held to account for this, but as an overall incident, we want to know what lessons can we learn to make sure that it doesn't happen again. In terms of there are no lessons, we can learn no lessons, that's pretty doubtful. Often somewhere along the way we can reflect on the whole episode of care for that patient and say, well, actually that's the bit that we could have done differently. It may not have been the root cause of the pressure ulcer, of course, so there are lessons to be learned. If we don't find a root cause, because every aspect of preventative intervention was visible, recorded, evident, and the patient developed a pressure ulcer despite all of those interventions, then you can say, you know, we don't have any lessons to learn here. The nurses and their team and the medical staff and the professions allied to medicine did everything they possibly could. So that's the kind of cutoff, but it's just remembering that. Would you agree, Alison?
Yeah, I mean, and that's why we have the root cause analysis process, you know, to look at the root cause of the pressure ulcer, you know, where's it started from. You will often find something when you delve deep, and important to that is the documentation, because if documentation is really good, valid, intact, then when we are looking then, you know, backwards to when and before the pressure ulcer actually occurred, what happened leading up to that, you know, it will you know, tell us a great deal. And to, you know, to speak to the patients and the carers, the family, everybody who was involved in you know, leading up to the pressure ulcer development.
Okay, thank you. And now we've had quite a few questions actually around non-compliance. So can you discuss non-compliance, especially where an investigation may take place, where this has been a factor, and really how to manage non-compliant patients?
Yeah, I think understanding or seeking to understand why the patients are not engaging with that with the plan of care, how do we get this patient, because it's not about telling the patient what to do, it's not about them complying, it's about them engaging with you as a healthcare professional. And so the first question would always be why. You know, okay, I completely respect the fact that you don't want to use this mattress, but can you tell me why? Because there are other mattresses, and that we might be able to look at something else. And if there's nothing in British Red Cross, then we can look at maybe something bespoke for you. So it's not handing them everything on a plate, which is not within the finite resources that we have, but it's about recognizing not everything suits all patients. And also the important thing of capacity. Is this patient making an unwise decision and they have capacity, or actually are they not able to make their own decision? And actually that then becomes more about safeguarding, in terms of why are they, understanding if they have capacity and why they're making that decision. And if they're not making the decision because they can't, and a relative is making the decision for them, then we can go down the safeguarding route. But if we feel that the patient is not engaging, then certainly within my organisation we can take that for support to our safeguarding team and to the review panel for discussion. But it may be that we go and see the patient, and that we formalise that patient's decision and look at the engagement checklist, which is in quite a lot of detail of why does this patient not want to engage with that particular service. It's a tricky one, I know, but I think the key is about finding out why and what else can be tried, and not just saying, oh well, they don't want it, so we'll discharge them. It's certainly not about doing that.
And we are going, when patients are in community, it's very different to patients when they're in that acute setting. So we are going into their homes, and patients have told me sometimes in the past, they understand the information, they can process it and everything else, but they don't want their houses turned into a hospital ward sometimes, is what they've said. So, sometimes it's just around certain things like that. So we have to respect, sometimes people make poor choices, but just make sure that everybody is very well informed, and have comfort, dignity and safety all together.
So the question is, we are instructed to turn patients 2 hourly, even at night. Is this really more important than the patient getting a good night's sleep?
There was a lot of talk about this in the past couple of years. There was an article that was published around this. It created a lot of chatter around it. And again, it's back to that, it's individualized care planning, and, that patient quality of life. We do follow our guidance, such as NICE guidance, European Pressure Ulcer Advisory Panel, and it tells us in there about reposition if somebody is at risk or has a pressure ulcer. But, if sleep is an important element of somebody's well-being, as is, nutrition. So we have to look at all that on that individualized basis. What is the greater risk? And do we need to be? And we have systems, we have great equipment now, really offloading floated mattresses that reposition without us having to make those physical turns. So look at resources that are available. Alison, you'll have an opinion.
Yeah, no, I would. Yeah, I would completely agree. Patients aren't turned 2 hourly in the community, so the 2 hourly turning is probably more of an acute policy. And I would agree that does disrupt patient sleep. If we expected carers to do that in the community, the carers who may be quite elderly themselves would be confused with sleep deprivation and probably delirious. So we have to look at that impact as well. And the equipment compensates for that. 2 hourly repositioning, we believe, and I'm not old enough, well, I feel as if sometimes I'm old enough to have worked with Florence, but it certainly came from Florence Nightingale. We believe that she was repositioning the soldiers every 2 hours, because that was the time span to get down one side of the Nightingale ward and up the other. And those patients, those soldiers, were lying on wooden planks. It's very different to what our patients, and yes, there are different risks, but it's very different to the equipment and the high level of pressure relieving equipment that our patients have today.
It says that in-bed automated turning systems tend to achieve 30 degrees of tilt to relieve pressure on the sacrum. Is this a clinically effective method for preventing pressure ulcers, or is a full turn to the patient's side with carer assistance preferable?
30-degree tilt is what we want to aim for anyway, and you can even sometimes go slightly less than that, but you don't want to be turning people over right onto their side, onto a full turn, because we don't want them on their hips, because their hips are going to break down. So with a clever use of pillows, and I know pillows sometimes in some settings, there just isn't any pillows, but you or the sleep systems, you can achieve that. So it's that tilt, that offload off the sacrum when somebody is in bed.
Yeah, I would agree. And there are mattresses now that can produce, a 30-degree tilt every 10 minutes, or you can set it to every hour, or the technology for mattresses currently is really good.
Yeah, and for people in their own homes, like we were saying, in community, I've had patients where they live on their own and they have pressure ulcers, and we've put tilting devices in place, and and it's been very, very successful for them.
Yeah, and cheaper than employing a carer, 2 carers overnight to reposition. Yeah. So actually, if we apply to continuing care for funding for those beds, they're more than happy because it's cost saving.
It's a good point there, because sometimes it's like there's always the bottom line on equipment purchasing, and sometimes like, oh well, it costs this much money. Actually, if you calculate that, and I did that once with it, and looking at night carers, the cost saving is significant amount. So